Okay, hi everyone, and welcome to the 2020 Graduate Student Research Symposium. We are so glad that you are here today. We have a really great day lined up that we've been planning for a couple of months now, and so we're just so pleased that you're here. To start off with this event, we have a fantastic speaker panel with three of our faculty from OVC. The theme of today's panel is a One Health approach to the COVID-19 pandemic. And again, we have a fantastic lineup of people today, starting with Dr. Amy Greer. Dr. Greer is a Canada Research Chair in Population Disease Modeling and an Associate Professor in the Department of Population Medicine. She's previously held scientific positions in the Centre for Communicable Diseases and Infection Control at the Public Health Agency of Canada and the Dalla Lana School of Public Health at the University of Toronto. Her research program explores the introduction, spread, dynamics, and control of infectious diseases in populations. She integrates empirical data with mathematical models to test the mechanisms leading to the epidemic spread of pathogens and identify optimal intervention and control strategies. Her research aims to examine the effectiveness and cost-effectiveness of both public health and veterinary health interventions to make informed decisions regarding public health policy. With respect to this pandemic, Dr. Greer is a member of the Public Health Agency of Canada COVID-19 Modeling Expert Advisory Group. She has published 6 papers with, I'm sure, more coming on different aspects of COVID-19 transmission dynamics and public health interventions, as well as opinion pieces on infection prevention and control in schools and parenting during a pandemic. She's been featured by numerous media outlets, including CBC, the Globe and Mail, National Post, Global News, Maclean's, and Toronto Star. And I just cannot wait to hear from her. Our second speaker is Dr. Katie Clow. She is an assistant professor in One Health in the Department of Population Medicine. Her research focuses on the ecology and epidemiology of vector and vector-borne zoonoses, with a specific emphasis on the black-leg tick and Lyme disease. She also conducts research more broadly on One Health, including pedagogy and community-level applications. She holds both a Doctor of Veterinary Medicine degree and PhD, and has worked in small animal practice as well as at the national and international level in One Health through internships at the Canadian Food Inspection Agency, Department of Food Safety, Zoonoses, and Foodborne Disease at the World Health Organization, and the Global Disease Detection Branch of the Centers for Disease Control and Prevention. She is a member of the Canadian Lyme Disease Research Network and regularly collaborates with public health professionals and veterinarians in private practice and industry. Fantastic. I cannot wait to hear from Katie. And our last speaker is Dr. Scott Weese. Dr. Weese is a professor in the Department of Pathobiology and director of the Center for Public Health and Zoonoses, and chief of infection control for the OVC Health Sciences Center. He also works as a veterinary internal medicine specialist with a focus on zoonotic and infectious diseases. His research focuses on a range of infectious disease issues of animals and humans, including antimicrobial resistance, antimicrobial stewardship, emerging infectious diseases, and infection control. Dr. Weese has authored or co-authored over 200 papers in peer-reviewed journals, edited 2 books, and writes and speaks on infectious disease topics, including on his Worms and Germs blog. With respect to the COVID-19 pandemic, Dr. Weese has been featured extensively in the media, including by the Washington Post, Global News, CBC, CTV, National Post, City News, and others. He has also acted as an advisor to university administration on how to reopen safely. And like the others, I cannot wait to hear from him as well. Before we jump into our panel, I just wanted to do a couple of housekeeping things. The first, we have potentially people from sort of all across Canada who might be joining us today. So if you want, you can say hello and where you're from in the chat. At the end of today's speaker panel, we'll be doing a short Q&A with questions from the audience. So as you're listening to what our speakers are saying, if you have questions for them, please feel free to write the questions in the chat and we will be able to address them at the end of the talk. So to get us started, I'd like to ask Katie if she could comment on what exactly is One Health. This is sort of a buzz term that gets thrown around a lot, but what exactly does that mean? And sort of in your regular sort of pre-COVID work, how have you implemented a One Health approach in your research?
All right. So great question, Lauren. And I think you're right. One Health is certainly a buzzword that a lot of people throw around. I think for me, when I think of One Health and emphasize what it means, it's an approach. And the key word that's in there is collaborative. So I think of a collaborative approach that brings lots of different disciplines and people together to work on complex problems that arise at the interface of human, animal, and environmental health. And I think about sort of two key tools that are helpful in a One Health approach, and that's systems thinking. So thinking about all of the interconnections and things that are linked to the issue at hand so you can really get a fulsome understanding. And then also transdisciplinarity, which really sort of relates to collaboration, but looks at how we can bring lots of different disciplines and different perspectives together to generate new knowledge, which wouldn't be possible if we were just sort of working in silos individually. In my day job or everyday research, so most of my work focuses on vector-borne zoonosis, which is inherently sort of a One Health issue. We have human, animal, and environmental components. And I don't think I would be able to adequately conduct this work without really addressing all those intersections. And so where One Health really comes into play is building collaborations and working with other people to bring in different expertise. So I have expertise in veterinary medicine and vector-borne disease, but there's lots of other aspects of it that I don't have the expertise in, and we all need to work together. That being said, I think it's always a work in progress. So I am nowhere near a perfect One Health practitioner. But I think if we acknowledge that we need to keep working together and sort of bring in more perspectives, I think we can get much more strength in the work that we're doing.
That's great. Thanks, Katie. Amy, how would you sort of add to Katie's definition of One Health, and how do you use it sort of in your regular pre-COVID research programs?
Yeah, so I very much agree with Katie's definition and how she's speaking about One Health. And certainly my program of research is what I would kind of consider a traditional One Health sort of program, in that our work has really primarily been on zoonotic disease and infectious disease related topics. But I think, more broadly, we are starting to recognize, and I think COVID-19 is the perfect example, that, the people, environment, animal kind of interface incorporates a lot of additional things that historically, from a One Health perspective, as somebody who's been doing this for a while, we did not originally think very much about the social sciences and about really the interdisciplinarity that is really required to do this sort of work and to do it well. And I think with COVID-19, for example, we're really starting to see, behavior, human behavior plays a really big role in our available public health interventions, as an example. And so, we have not historically had a lot of interaction in my group with social scientists, with behavioral scientists, with people who work on social justice issues. So I really think that, in the last 5 years, especially, the area has really broadened quite significantly to make meaningful impact in ways that even, when we first started down this road of One Health, were not traditionally considered. Traditionally it was mostly people working on zoonotic diseases. And I think it really has broadened in terms of scope quite significantly and with very good outcomes.
That's great. Thanks, Amy. And I do really appreciate your observation of the inclusion of social and behavioral sciences as sort of an important partner in a One Health approach or in responding to One Health issues. Scott, how would you add to what you've heard, and how do you normally use it in your research?
Well, I think both those are bang on. So it's an approach, and people ask, are we training One Health specialists? And I don't think we are, because I don't think there can be such a thing, because you have to be, you do 25 PhDs and an MD and an RN and a DVM. Like, I think we're training people how to understand the approach and how to do the collaborative work and how to broaden our horizons. And I think Amy has some great concepts about moving into the social sciences, which we've been trying to do for a while. And I think in the human side of the COVID response, they're doing a better job at that. I wouldn't say a good job, a better job. But I think also, here's where my grumpy guy comes in here. Like, I think COVID has really shown that One Health is currently still a major failure. The One Health response to COVID has been abysmal. Once this became a human disease, no one gave a crap about One Health. Like, this is a classic One Health problem, right? Came in animals, moved into people. We don't know where it's going to other people. We don't know what the environmental role is. And the response was, well, okay, well, prove there's a problem and then we'll think about it. WHO, CDC actively avoided considering an animal aspect, an environmental aspect. Like in January, I was emailing the Ministry of Health and Public Health Ontario saying, okay, with SARS-1, we tried to address this, but it was during chaos mode, so we can't think about the animal side. Like, what about this escaping into wildlife and domestic animals? So I said January, and like, this is mid-January, it's a great time, this is gonna hit us probably, so let's make some plans. Let's think about what the animal size might be and how we can do it in advance to be proactive. And response was, okay, we'll get back to you. And that got filed in the circular file pretty quickly, and there was no response there. WHO and CDC initially said, well, there's no evidence other animals can be affected, which is true, but no one looked. And then they said, well, there's no evidence animals can get sick. And then there's no evidence animals can transmit it to people. And those have all serially been proven to be wrong, which A, shows we missed opportunities, but also shows you miss opportunities to provide confidence, which is a big issue with COVID response, is not trusting authorities. So that's a bit of my kind of rant where we are with One Health. I think One Health still has a long way to go. It's what we have to do. But this has shown that it's a big failure. If we can't capitalize on COVID, it's dead in the water, right? If this can't make us do One Health, then we're never going to do One Health. Because we've been doing this for a while. Like, all of us here, my background has been One Healthy before it was called One Health, where we do zoonotic disease and we look at that human-animal interface. And we haven't, my side isn't in the environment that much, but all my work is infectious diseases. And most of these are a large percentage of these zoonotic diseases, or their antibiotic resistance, which crosses over, or they're emerging diseases that we don't know about. So there's always been a One Health component there. So there's this pool of people that really get One Health and want to do One Health, and they're trying to expand it. But getting it beyond, the preaching to the choir component is still a huge challenge. Sorry, end my rant here.
No, that's totally okay. And Scott, if I might ask you, do you think One Health is challenging for sort of to communicate to the general public what exactly that means? So if you're sort of a researcher in One Health, you understand what's going on, you understand its importance. But is there a need for sort of more communication to the public about the importance of this approach?
Yeah, I think there is. I think we need more scientific literacy. Like, I don't care whether it's One Health or not. One of our biggest barriers to COVID response is scientific literacy. It's people being able to understand why we need to socially distance and why we need to mask and why we're talking long time frames, because they don't know how to assess science. They don't trust science in a lot of situations. They don't know how to critically assess the Twitter post that gets them all upset, or the Facebook post. So we need to engage the public more in general. And I think they need to understand the One Health approach. But I think one of the bigger issues with One Health is decision makers. There are some decision makers that very much get it, and there are many, many, many that don't, because it's not been their area. It's still a new field in terms of One Health. And if you look at people, if they haven't grown up in that, and we're also in an area where, people are busy and it's expanding. So it's going to take time. But I think there are a whole lot of barriers, and that, we need the public to understand it, so the public asks for it. We need decision makers to understand it so they can affect it and fund it from a research standpoint, but also from a structural standpoint, is how do we actually get people together? Amy's comments about the social scientists are great. We need behavioral modification. Like, the science is easy on a lot of this stuff. Microbiology is really easy. The epidemiology can get sorted out better situation than the anthropology, sociology behavioral science stuff, and that's where we fall apart. We can tell people we can know exactly how to control this virus. I'm not saying we do, but we could know exactly how to control this virus, and it would potentially fall apart because of that communicating to the public. So I think we need to hit a lot. It's a long-winded answer to, we definitely need to engage the public amongst kind of everyone else, and we need to engage the corresponding professions, right? You need to engage the social scientists. We need to engage the physicians, because physicians as a group, I don't think get it. I think some do very well, but as an overall population, it's not been on their radar. It's not on their training things, not disease aspect, environmental health aspect tends to be very low for a lot of people. So like everyone needs to get more out of it, I think. That's my take home.
Absolutely. Thanks, Scott. And that's actually a great segue into talking a bit more about why a One Health approach is useful to responding to this pandemic. And Amy, maybe I'll turn to you here. You've sort of been entrenched in responding to COVID-19 from the beginning, and I'm sure you've brought a One Health lens to the work that you've been doing. But sort of from a broad perspective, just to get us going, why is this approach useful when we're responding to pandemics like COVID-19?
So, I think what we need to think about, and most of the people on this call are probably aware of, which is that, whether it's this pandemic or a future pandemic, in almost all pandemic instances, we will be looking at an emerging infectious disease spreading into the human population, transmitting rapidly, for which there will likely be no vaccine and no reasonable pharmaceutical intervention. So when I say pharmaceutical intervention, I mean vaccine, but also, treatment in hospital. For COVID-19, if we had an existing, really great, effective, safe in-hospital treatment to, minimize the mortality that we see in people who are experiencing severe illness, that would go a really long way. In the case of this emerging disease and, likely in future emerging diseases, in the absence of that, in the absence of therapeutics, in the absence of vaccine, which we know is going to take time, what we are left with are non-pharmaceutical interventions. Non-pharmaceutical interventions like hand hygiene, cough etiquette, physical distancing, masking, all of these sorts of things, school closures, workplace closures, they hinge so dramatically on human behavior. And, for me, I think that the other challenge is that when you layer the disease dynamics into that sort of setting, I actually was quite surprised in March when as a province, we decided that we would act, the challenge is it's difficult to act in a way that appears very reactive, like closing schools, closing workplaces immediately when case counts are still low, right? Convincing the public that that's the right approach when they look at the case counts and they think, oh, it's not like we're not overwhelmed, but that is the paradox of prevention, right? That's what we call in public health the paradox of prevention, which is that people will say you're overreacting, and then when nothing dramatic happens, they say, oh, look, nothing happened. Public health was overreacting. When really what happened was public health reacted very strongly, and that what we observe in terms of the fact that, we were not New York or Florida or Texas or any of these places is a function of what we did. And that in and of itself is a really challenging concept to communicate to people, right? If you wait too long, the disease dynamics are like a freight train, right? If we put the brakes on after we're already at a really super high case count, it's going to take us an awfully long time to be able to slow that dynamic back down. And I think the math, we do a lot of mathematical modeling, and what I would say is that the math of epidemics is consistent, right? I mean, we know that is a disease dynamic observation. It's a mathematical observation. And it doesn't really matter what pathogen we're talking about. If we wait too long, it will take a very long time for those non-pharmaceutical interventions to be able to rein transmission back in. And so, the idea of behavior, and like Scott said, scientific literacy, we are working in an environment in which media consumption, where people are consuming their media from. You know, we have colleagues at the University of Toronto who are political scientists who study media consumption in the Canadian population. There's really interesting information about, you know, how trusting of public health messaging people are based on, you know, what websites they tend to frequent. So, you know, I think there's a lot to be said for social science, especially when we know in this pandemic and in future pandemics, behavior change is going to be our key way to keep transmission low. And we have to find ways to understand how people make decisions and to be able to influence those decisions in a positive way.
I think maybe to jump in one of Amy's points there about this isn't the last outbreak we're going to see. This is our third major coronavirus jump in the last 20 years, and everything that's bad isn't coronavirus. Like there's an estimate of what 1.7 million viruses I heard someone estimated are out there. Who knows where they got that number, but at 0.00 whatever percent are human pathogens. That's still a big number. So, you know, we're going to see something else. Is it going to be in 2 years or 100 years? We don't know. And that's the other thing we have to be thinking about in this outbreak from that response is how do we make it better? What were our gaps here? And, you know, are there low-hanging fruit? There are a lot of low-hanging fruit when it comes to communication and surveillance and restriction of animal movement. Like we're doing some work now with international movement of animals, right? What if the first animal that had this virus was a species that was imported into Canada legally or illegally? Because both those happen in dramatic numbers, right? Then we'd be the epicenter, not Wuhan. And every time we move a person, every time we move an animal, we create some risk. Every time we move into a more remote area or we bring those individuals into us, we create risk. So we need to be thinking about the next thing that's coming at the same time and take advantage of some of the interest right now.
I think just to follow on Scott's comment is that talking about coronavirus is just in general is that, you know, there's actually a document that was published by the WHO in the early 2000s. And I think it was like a list of like 10 groups of pathogens that, you know, as a globe, we should be thinking about as having significant pandemic potential and for which we should be actively thinking about vaccine candidates, you know, preemptively getting some of the pieces in place. Coronaviruses are at the top of that list, and that list was published in early 2000, and yet here we are in 2020. It's like we're starting from scratch, right? So it's, again, this idea of One Health. You know, we had a list of what we consider to be, you know, high potential for pandemic transmission and pandemic scenarios of pathogens that are found in wildlife, where we knew the potential exists, and that we should be using that list to plan very proactively, given that all of those pathogens are likely to have slightly different characteristics, right, in terms of morbidity and mortality, in terms of transmissibility, and yet, you know, we look back on the list now and think, boy, you know, that would have been really great if we had have kind of started in on that list 20 years ago, but here we are.
Yeah, I could agree. I absolutely agree with you, Amy. And also thinking back to the all the SARS commissions and reports that came out after SARS in the early 2000s and recommendations for improving our provincial and federal public health systems. I think probably most of those recommendations are still, you know, quite valid today. Katie, I wanted to ask you, as someone who's been sort of viewing the COVID-19 pandemic and probably always sort of having that One Health lens on, how are you sort of seeing and responding to this pandemic differently compared to someone who's not a One Health expert? So I'm thinking about sort of what are the questions that you're asking or the things that are concerning to you that are sort of informed by your One Health expertise compared to someone who perhaps doesn't have that particular viewpoint.
Yeah, I think it's quite challenging to sort of, once you have, I guess, more of a mind that thinks about interconnections and things like that, you can't really turn it off. And I think for me, you know, I've been more distant from the pandemic than Scott and Amy, more of an observer in my home, locked away. And, you know, I think when I see things happen, I'm always asking myself, okay, well, what are the unintended consequences of this action? Have we brought in the right people to understand, okay, well, we know what we we want to happen with this action, but how is it going to have, immediate or long-term effects in other ways that we didn't really predict. And I think, there's been lots of things that have had to happen very quickly, which is completely understandable. But I think in a lot of ways, when we sort of look at, were we prepared? Did we think about all of the different things that are going to happen when essentially you shut down an entire economy, and all of the sort of distal animal, human, and environmental health impacts that aren't directly related to the virus at all? I think I'm always kind of thinking about those things and wondering, in the future, can we do better? What sort of lessons can we learn from this? What can we do now to make sure that, some of those long-term side effects don't happen? And so I think that's been a lot of what's been going through my mind, is just asking those questions, and can we avoid those by bringing more people to the table, particularly social scientists, as Amy has talked about.
That's great. Thanks, Katie. Scott, as you've been sort of at a lot of tables at the University of Guelph planning for sort of phased in research and bringing people back onto campus, as a One Health expert, what are some things that you've been pushing for, or questions that you've been asking that perhaps have been informed by that particular lens that perhaps others around the table don't consider or don't come to mind right away when thinking about, particularly at the university level, how to bring people back safely?
Well, I think once we're dealing with this as a human issue, when you're talking about bringing in businesses, university, the One Health side, largely steps back. If we think about One Health as that animal and human environment interface, it more becomes the broad aspects that Amy was talking about, which isn't really inherent in One Health, but is that multidisciplinarity. So I think you've got One Health, you've got these three different bubbles, animal, human, environment, and within each of those, you've got the need for multidisciplinarity with the behavioral sciences and everything else. So I think if we look at a lot of things, if you're looking at businesses and you're looking at, the university, most of this is focused on human behavioral aspects, infection control, basic principles of surveillance. There are some areas where we get outside the One Health, and that gets us into the animal side, the teaching hospital, research facilities, wildlife surveillance, things like that, where we start to get into that animal and environment component, and it gets trickier because we don't really know. So we certainly know some animal species are susceptible, so that raises concern for us infecting things like wildlife species or domestic animals. And we also know there's potential for animal to human spread. It's been seen with mink, but other species we don't know, but there really hasn't been good investigation. And figuring out if a cat infected a person is really difficult in the context of rampant human transmission. So it's one of these, being prudent approaches. How do we be prudent with the hospital? How do we be prudent with research facilities, environmental surveillance, balancing that practicality and protection at the same time? And that's the challenge, right? How do we function in the teaching hospital, protecting ourselves, protecting our clients, but maximizing care? How do we maintain research facilities without infecting a group of pigs? That could be a big issue. How do we do field research without worrying about infecting wildlife species that we don't understand? So that's bringing in principles of, what do we understand from experimental models, from field work? What do we understand from transmission? And that could be human transmission, it could be animal transmission. What do we understand from principles of infection control? Because, the way I'm going to prevent myself from infecting you is the same thing I'm going to do to prevent from infecting a cat or a pig or a dog. There's still that type of exposure. So it's a lot of similar concepts. So the One Health side comes in selectively, but I think as it becomes as we're focusing just on human situations, then it becomes a multidisciplinary human infection control issue.
Thanks, Scott. And Amy, I'll turn to you. I know you've been working with a lot of provincial stakeholders as sort of the epidemiological expert. How do you bring your One Health lens to that table? And have you found it difficult to sort of get the importance of One Health across when speaking to policymakers or stakeholders or other people that you've been interacting with?
Yeah, so I mean, I would echo what Scott has said, which is that One Health is not at the table. Like right now, our interactions, whether they're provincial or federal or with other stakeholder groups, the One Health perspective is not at the table. Right now we are focusing on this primarily as, a human public health emergency, and we are managing it in that way. I think that in general, there are a number of things that continue to be significant unknowns. And, one of the things that Scott brought up, which is really interesting, is that, for instance, SARS-CoV-2, so this virus is related to another coronavirus called Middle East Respiratory Syndrome coronavirus. And, the interesting thing about MERS-CoV is that it does not seem to be as transmissible between people. So that actually has a natural animal reservoir, which is dromedary camels. And camels kind of appear to not be symptomatic primarily, and that you can get spillover of infection into humans who have direct camel interaction or who drink camel milk, for instance. And most of the human, person-to-person transmission has been associated with hospital outbreaks. So, somebody who has contracted the virus shows up at hospital and it doesn't get flagged as a potential MERS case until, healthcare workers, for instance, who've had really close contact with that person become infected. So you get kind of small chains of transmission or clusters in healthcare settings. But this virus is very similar to SARS-CoV-2. And so one of the questions is that, are there other camelid species in Canada, right? I mean, there are, in fact, in zoos, on farms, not camels specifically. I mean, alpacas are camelid species, and there's a lot we don't know, as Scott said. Pardon me?
I have 5 of those.
He has 5 of those. I love them. They're so lovely. But I mean, it raises important questions, but none of that is on the table. I mean, right now, in terms of pandemic response, the response is very segmented. Response right now is human focused. All of the response is around testing, tracing, isolating, lab capacity, surveillance, non-pharmaceutical interventions. And, I think in the next go around, I think that, as Scott said, it highlights the fact that it's still not on the table, right? And I think that it needs to be more. It needs to be a more integrated approach. And to be honest, the shocking thing about an integrated approach is that, I've sat on a number of committees related to the Canadian Pandemic Influenza Plan for the health sector. That plan has, very detailed appendices on lots of different public health interventions like vaccine and surveillance and lab capacity. So I had always assumed that other industries, other segments of, our government had pandemic plans for, what they were going to do in the case of a pandemic. But it turns out that while they do have pandemic plans, they are very minimal. They're focused on business continuity only, right? So like, if everybody has to work from home, do they have, access to a VPN to be able to install on their computer? I mean, that at this point is very low on the list of things we need to manage when you think about trying to return people to their office. We're talking about massive engineering controls and how are you going to do that in a safe way? The fact that we have school reopening plans that are such a mishmash of insanity right now highlights the fact that, have we not had a pandemic plan for, the idea that in the case of a pandemic, we might have to close schools and that there would have to be some plan and operationalize a plan. To me, it's been very eye-opening because I think we have assumed that many of these different sectors are integrated under some big umbrella, and the answer is they are not at all.
If I can maybe jump in with some of the stuff what did we learn from SARS-1 and what didn't we learn? Like I got this slide I used in presentations for 15 years now that basically says, okay, and actually we wrote a commentary in Emerging Infectious Diseases, a pretty high profile journal, basically saying, okay, well, we know that SARS-1, like we know now that SARS-1 you can infect cats with it, you can infect ferrets, and they could spread it amongst each other. But during SARS-1, we had thousands of people under household quarantine, but I could be quarantined in my basement And the cat runs down, and I cough on it, I pet it, and it runs up and it hangs out with my kids, and it goes outside and hangs out with the animals. We didn't think about that. Did we get lucky that we didn't infect the cat? Because if we had SARS and feral cats in Toronto, that'd be bad. And, I've been saying this for 15 years, but, I could write that commentary again tomorrow and it would apply, because we've got a little more consideration now because we've been yelling a little bit louder about it, but still we're not getting into that broad approach, and we're not learning many lessons. Like, this is obviously a bigger issue, so maybe we'll learn more. But SARS was a big deal in Canada. And like you mentioned, the SARS report, some things happened, some things didn't happen, some things happened and have gradually been chopped away, kind of in relationship to what Amy was saying. But when you get successful, you get compromised in infection control, because why should we spend the money on doing this? Because we don't have a problem. It's like, why do we vaccinate against measles? I haven't seen measles. Well, you haven't seen measles because we vaccinate against measles, but that's the problem we run into.
Absolutely. Katie, I wanted to turn to you. You sort of mentioned that, although not sort of directly involved with the response, you've been sort of observing it as someone sort of in your home. And I wanted to ask you, what has sort of surprised you most about this particular pandemic? I think it's obviously the first pandemic we've all really been, living through, at least one that's really impacted our lives in the way that this one has. So yeah, as a One Health expert, what's sort of been most surprising as you've been watching this pandemic with, zoonotic origins?
I think everything has surprised me, and I think, I will be the first to admit that I wasn't a proactive thinker like Scott was back in January. I was wondering, are we just blowing this out of proportion? Because sometimes that happens, especially in the media. And, we did a case study in my One Health class on this, particularly around systems thinking. And I don't think I ever really thought that then the last, 2 weeks of that course were going to be delivered online. And everything has kind of surprised me since then. I remember a conversation I had in the parking lot about a day before the shutdown happened with Dr. Papadopoulos. And he was saying, it's probably going to be a couple weeks. We'll go home. Everything's going to calm down. And I was like, oh, yeah, that sounds like a great plan. And so I think, I wasn't prepared for what happened. But I think, I think a lot of things have really just surprised me in how this kind of played out. But, I think there's been a lot of really good science that has come out, and it's been, interesting to watch. But I guess, it's not a very good question or answer other than saying that everything has kind of surprised me. And I think I'm a little bit more prepared now for the future, that this, we're in it for the long term, and that it's not going to be an easy solution, and it's a very complex issue that has to be dealt with.
Absolutely. And Amy, I just remember in your last sort of response, you were talking about the fact that, you sort of assumed there were all these plans that existed somewhere, and some sort of integration that existed at some sort of higher level that perhaps we just all weren't aware of. But in fact, those things sort of don't exist. Was there anything else that you found out sort of through your work in COVID-19 that, you weren't aware of before that, perhaps was surprising to you?
So I will admit that in 2009, during the 2009 influenza pandemic, I worked at the Public Health Agency of Canada at the time, and somebody said, we're doing all these models for vaccine deployment and vaccine prioritization, but like, what if you only had non-pharmaceutical interventions, right? Like, what if for whatever reason, all we had to work with was physical distancing? And at the time, we weren't even calling it physical distancing, right? Like, what if the only way you had to control transmission was to drive the contact rate down in whatever way you want to make that work? Reduce the contact rate, because we know contact rate is such an important parameter in those models. And I remember saying, well, we'd never obviously if you reduce the contact rate, you're going to slow transmission. do we really need a model to do that? And I remember this person saying, well, it'd be interesting to know, based on what the transmission characteristics are of 2009 H1N1, like how much would you have to reduce the contact rate and how long would you have to do that in order to kind of really significantly reduce morbidity and mortality? And we wrote a paper in 2010, and that paper said, oh, geez, you would really have to drive the contact rate really low, and you would have to it does not work unless you act very dramatically and you maintain that for a very long period of time. And I remember writing in the discussion, getting people to do this at high compliance for a long period of time is going to be near impossible, right? The model says this is what you would need to do. And if you had like a highly transmissible virus, like a 1918 type influenza, the only way it works is if you have high compliance to very, serious reductions in contact rate maintained for very long periods of time, and thinking, geez, let's hope we never have to do that. And then here we are, right? And I was quoted in the National Post. We wrote a paper in March that said exactly that. That said, in the absence of vaccine, what we're going to do is basically limp our way along to a vaccine, and we're going to do that by shutting down transmission, by acting in ways to reduce the contact rate. We're going to start to slowly reopen based on some prioritization of different types of businesses and different economic activity. We're going to open up slowly. We're going to monitor. And as transmission starts to increase, because it will, and once those cases start migrating into older individuals who are going to be people who are going to require healthcare resources, so hospital beds, ICU beds, ventilators, once we start to see movement in healthcare, we have to protect capacity. And if we are going to exceed healthcare capacity, we will have to clamp down. And so the title of the National Post article was like, Epidemiologist says we will be social distancing for, a minimum of 8 months or something like that. And people sent me hate mail. Like they sent me like very angry emails, like, their kid was going to miss their prom if that was true. And, all of these things. But that's, I wrote that paper in 2009 and I thought, geez, I really hope we never end up in a situation like that. And here we are, right? We are asking people to do something that is very difficult, and we're asking them to do it for a very long time. And we know it helps. We know it works. Compliance fatigue is real, and we're seeing that already. We're seeing it in case counts that are starting to increase already. Our reproductive number nationally is creeping up over 1 and has been consistently over 1 the last 7 days. It is starting to be a yellow flag. The yellow flag is flying in terms of, and school hasn't even started yet. So, that's where we're at.
I've been interested to watch BC's response. So initially, they had a very sort of strict response, and people were sort of lauding them as sort of being able to contain the outbreak quite quickly. And now they're starting to see case counts rise up again, and they actually have chosen not to start, or at least the last I read, not to start phasing back activities, because most cases are in sort of young adults and we're not seeing hospitalizations go up. Amy, as you're sort of watching that, are you sort of saying, Ontario, do not follow suit, or how have you sort of been responding to that?
Yeah, the fact of the matter is that this is, while we say young people are lower risk, certainly younger people have less, have a lower probability of a severe outcome, but that does not mean that there are not young people who get very seriously ill. So that is important to recognize. But this is kind of where the metrics are, right? In terms of monitoring those data and saying, at what point would we need to start phasing back? Because to go backwards is going to be hard. It is going to be very difficult to convince people at this point that we need to scale back down. And to do that, you're going to need to be able to support the decision with data. So, here in Ontario, one of the things we've been talking a lot about is, cases in young people, keep an eye on it. we are starting, as of this morning, to see increasing test positivity in people in the province who are in the age group 50 to 59, which suggests, so what happens is you get transmission in those younger age groups, and at some point that's going to start percolating up into the older age groups. So sure, we can keep where we're at right now. Once it starts percolating into older age groups, though, that's when you're going to start to see hospital admissions, ICU admissions, ventilator use. Those are limited resources. And so, if we can keep it in the lower age groups, then, that is less of an issue, although it certainly is not zero risk. As we start to see it percolate into older individuals, as we have predicted will happen, because younger individuals have contact, college-age students have contact with their parents and have contact with their grandparents. And as it starts to percolate up, those are the metrics. When we start seeing cases increasing in people who are high risk, then we start seeing movement in those hospitalization numbers. That's going to start to turn the red flag on to say, at what point do we say we have to protect healthcare resources and we're going to have to scale back? It's going to be hard to convince people to scale back when all of the cases are in young people right now.
And I think one of the problems is the politicization that's largely come from the US is it's not binary. It's not wide open or completely locked down. If you look at Ontario in the last month, it's not normal, but for the majority of the population, it's not, that abnormal. Yeah, the distancing stuff, but there's a lot of low-hanging fruit that's there. It's when you get into restricting things that severely impact people's lives and their economic activity. Sure, you can't go to the gym, the kids aren't playing sports, and the sports thing is a big thing, schools are a big thing. But there are ways to control contacts, to control behavior without being profoundly disruptive. So that, and combined with rapid testing, ideally if we get rapid saliva-based testing, there are ways to kind of find a middle ground. And I think that's the problem in the US is they just push back. It's either I'm not wearing a mask or I'm wearing a mask, and that's all we're going to talk about it. And there are a lot of other behavioral things that can be done, and it's difficult when you've got a country that's so varied in terms of race, and even a province is so varied in terms of race, and within a health unit it's so varied in terms of race. Bringing out something broad is always going to get some pushback, but ultimately that's why the leaders are paid the big bucks, right?
Actually, that's a great segue. Scott, I'll stick with you. As you've been sort of watching the decisions that have been made, particularly by government with respect to infection control, what are some of the things that you've been pleased to see that Canada has either been embracing or leading during this particular pandemic?
Well, you can split that into the big stuff, and then maybe the one quickly the One Health side. The One Health side, I've been pretty pessimistic about, but in Canada we've done a better job with it. We have a national working group that started very quickly with Public Health Agency Canada, Canadian Food Inspection Agency, the provinces. I'm involved with that, thinking about the animal aspects, and we took a line very early that said, that the animal risks are low but not zero. So we need to pay some attention. We're gonna do this, that, and the other thing to pay attention, and we've got proactive plans for things like farms and the like. And I think, and Amy could talk better about this, but the data availability, the data sharing, the data transparency has been a lot better than certainly in the US, where there's so much political control. So I think Canada has done some things. We've dropped the ball in a lot of areas, but we've done some things that are quite good overall. When it comes to the kind of the ongoing response, a lot of it's the social science side that's the key right now. How do we make people do what they know they need to do, they don't want to do, right? How do we make people continue to wear masks? I think one of the big things about Canada is once governments got around to mandating masks, that caused a huge behavioral change, right? Canadians are pretty good at doing, when masks were optional, compliance rates were low because people didn't want to bother, or they felt weird, or they felt like they were being, I'm being a germaphobe because I'm wearing a mask. They didn't really understand it. Once it became mandatory, you feel like, in Guelph, it's very rare to see someone inside a store without a mask on. So I think we've adopted that very well as a public. And I think we've adopted the social distancing fairly well. It's a matter of maintaining some of those activities and really trying to avoid the high risk activities. So I think Canada has been, we've been better off in the US for a lot of reasons, but I think a lot of it is we've got a little more trust in science. Well, hopefully a lot more trust in science. I think we have a little more trust in politicians in terms of it's not as politicized, it's being done. And we've had some very good cross-party support for some things. So that has helped a lot. So I think one of the biggest things in Canada I think we've had better communication, we've had better trust, we've had better compliance, not across the board, obviously, but in broad terms, that's been good. We've had better data, which let us, substantiate things, let people understand a little more, let people monitor it. Because an informed population, if we have to do something, like Amy said, if we went to a straight lockdown, that's gonna be really difficult again, because everyone's been through issues. If we bring in more measures, it's very difficult. And this is just from infection control in general. So I deal with a lot of hospital infection control, veterinary clinic infection control. And if I just go in and say do something, you get the not going to do it, right? I'm doing because it's going to be something that I don't want to do, or it's going to be cumbersome, even to wash your hands, right? It takes time. If I say we have to do this because, then we get a better response, right? And that's what we have to be reminding ourselves with. In Canada, you can't just say, okay, now you have to do this. You have to present. You don't throw data at people, like throw a bit of data at people, but you've got to explain why. Because 90% of the population, whatever the number is very reasonable. They're worried about their kids, they're worried about their jobs, they're worried about everything else, but they're very reasonable. If you can explain that we need to do this, this isn't that big a deal. Wear a mask isn't a big deal. It's not it's not going to protect you completely, but it's going to do this, distancing, we need to do that. Or, we're keeping restaurants at low capacity because here's what we do and here's why we're doing it. I think that's the messaging that we need to continue. And the Canadian atmosphere is more accepting that right now. I think people will trust a little bit more, but that's one of the things we have to watch, that as it becomes overly political, if it splits off and becomes more political, then we risk a lot of compliance issues.
That's great. Thanks, Scott. And I know we're sort of nearing the end of our speaker panel. I wish we could talk longer, but I did want to leave a few moments for questions from the audience that have kind of been rolling in as we've been talking. And this one I wanted to give to Katie. So what is the public health role of veterinarians during the COVID-19 pandemic?
It's a good question. So I think Scott's been really involved with the veterinary profession, so he might be better equipped to answer this. I think, can I take a second to think about that?
Absolutely. Scott, did you want to jump in?
Well, I think there are a couple of roles. Like, the biggest role for veterinarians, especially companion animal veterinarians, is keeping the public calm. Like, the more people are willing to accept some problems, they're not willing to accept some things. So if my dog dies because my vet won't look at it, that's a huge impact on me for most people, right? So I think in veterinary medicine, we've had to balance, how do we protect our staff? How do we protect our clients? How do we protect our animals? How do we not infect animals or get infected from animals? And we put out a lot of guidance on how to do that. We certainly have had clinics closed down because they've had COVID come in there. But I think veterinary medicine can do food production, maintain safe, economic, welfare-based food production by providing animal care. We can make sure people can get care. It might be altered. It might be you drive to the vet clinic and they come out fully garbed up and they take your dog and say, see you later. But we're still providing care. So I think that's one of the big things that we can do. The other is preventing that human-to-animal transmission. So we don't want to create reservoirs in community cats. We don't want to create reservoirs in raccoons. We don't want to get into food animals. Now, the risks of food animals seem very low, but we don't know a lot. So veterinarians, through infection control and through how they act, I think can have a big role. But I think in the broader populace, it's really trying to say, we can do some things and still do our jobs, which is what you need us to do, as opposed to having people upset, because the more people can't get, the more this risk falling apart.
Great. And Katie, did you want to add anything?
Yes, Scott's better at thinking on his feet than I was there. I think, there was a big discussion at the beginning of the pandemic, or at least, within the veterinary profession, because if you looked at the sort of list of essential services from published by the Ontario government, veterinarians weren't on there. And that was a really big concern when you think about all of the roles that veterinarians play in society. I think just about the animal health and welfare impacts that if veterinarians weren't allowed to offer sort of emergent care. And, that would very, very quickly come into human health as well. If we think about any other emergency situation, the reason people stay in their homes and don't seek care or don't leave during evacuations or things like that is because of their animals. And I think that that's a really important thing for us to acknowledge in any emergency preparedness. I think too, and Scott commented on this, like veterinarians have a very huge role to play in our food supply. And if veterinarians weren't allowed to practice to ensure animal health and welfare on farms and in animal production facilities, that would be a really a big detriment to our society. And so I think that, you know, there's some research that we're starting too, and those are important conversations for us to have as we move forward in any emergency planning, is that, you know, veterinarians have an incredible role to play in public health and in society in general, and ensuring that those services can continue regardless of the emergency, that they have a really big role to play is an important conversation for us to have going forward.
Absolutely. Thanks, Katie. Very well said. Amy, I wanted to turn to you with this question. It's with respect to public trust in public health messaging and recommendations. I know you've been sort of in the media a lot and probably thinking quite a lot about how to convey a lot of sort of more challenging concepts in ways that sort of the general public can understand. The question is, have you noticed any specific methods of sharing information or types of information that were more successful in uptake by the public than others during COVID-19?
Yeah, that's a really great question. And I think one of the other things that has really come out of all of this, right, is science communication. And as scientists, as academics, I mean, none of us are really trained to communicate science to the public. And so, I mean, I think that's just, you know, an important thing for graduate students, especially to think about, right? There are lots of professional development opportunities to think about knowledge communication and science literacy and being able to communicate with people in the general public. And that's not something we're typically trained on. I think two things that have really, surprised me, but also been really quite positive have been, and as Scott said, you know, as Canadians, we tend to be rule followers, right? I mean, we've been quite easy to adapt to the normalization of a number of things like wearing masks and doing physical distancing. One of the things is that there are certain groups for whom we know things like mask uptake continues to be not great. And I would say that one of the things that I think has been really successful is to, again, turn to the social scientists. You know, when we work in, and my group, we've worked in sexually transmitted infections and bloodborne infections for quite a long time. And, you know, harm reduction as a public health approach in terms of thinking about the way we communicate public health interventions, right? So harm reduction strategies around needle exchange programs, around condom use, around all of these sorts of things. There's really great literature about how we communicate that information to allow people to keep themselves safe in a way that doesn't shame people, in a way that doesn't blame and shame about, you know, these are the bad behaviors and these are the good behaviors, and, you know, so you should just do those good behaviors, right? Or what we would say kind of our quote unquote good behaviors. So I think, you know, one of the really interesting things is that there's a lot we can learn in terms of communication from people who've been doing harm reduction, you know, since the early HIV epidemic. And I think that's been something that's been really great to see. Those are people who've spent their lifetime doing this and working to communicate you know, how to make choices to keep yourself as safe as possible, and that it's not just about you, it's also about your community and the people you come in contact with, and that there's nothing shameful about certain choices, but, you know, that there are things that we need to do as a society. And so I think that's been really something that, you know, we don't typically talk a lot about harm reduction, and because it's been kind of compartmentalized again into kind of a specific discipline of infectious disease work, but it applies to just, you know, trying to influence and change human behavior.
Absolutely. Thanks, Amy, so much. And just in the last minute, I'll sort of throw this out to the group, this last question here, because we've all sort of spoken about the fact that we have a spotlight on right now because of the pandemic, but, as this resolves over time, the importance of One Health, the importance of studying, zoonotic disease transmission, transmission dynamics, that can tend to take a back seat. So the question is, how can you demonstrate to the powers that be the tangible benefits of devoting money and resources towards prevention of future pandemics and outbreaks? And I think this is actually the million-dollar question. If we could just figure this out, we'd be in a good spot. But any sort of final thoughts on how we can sort of take this momentum and keep it going sort of in the post, COVID-19 era?
I think maybe one thing is, it's maintaining effort and maintaining interest in resourcing it. So, right now you might say, okay, it's the best time to get sustained funding for personnel and for integrative approaches and for surveillance and communications, and it might be, but we're also going to be entering an era probably of belt tightening. So it's how much, like, people forget really quickly. Like, if you got trillions of dollars of impact, you got hundreds of thousands of lives. So hopefully this will have a bigger impact long term, but it's very easy to start chopping some things off because they're not front and center. A lot of these activities, it's not like we're spending money on a vaccine plant. So governments will stand there, they'll cut a ribbon quite happily standing in front of a building saying, we're going to develop another 1,000 people that can contact trace, or that can do this, that, and anything. We're going to work internationally to help reduce animal trade aspects and exposure risk, and we're going to improve our surveillance and our communication programs. And Amy probably has 1,000 things they can do for data transparency and access. And we're going to improve the ability to share information, all those things. Like, that's where we need to go, and that's all behind the scenes. So that's my biggest concern, is that once belt tightening occurs and people forget, we're going to have a few flashy things that will happen, but we're not actually going to have the stuff that we need done. So I think that's a matter of keeping it up there. And I think that's where it's going to come to the communication, right? There should be thousands of PhDs done in the next 5 years about our response in all different areas, what worked and didn't work. And those are the things that need to be front and center all the time, because the media is going to get bored with that. We've got to figure out how to communicate to the public, okay, here's what worked, here's what didn't work, here's why we need to do it. So that people are asking for it. It's like, the vaccine. One of the things I've been kind of whining about for a while is, we're seeing ads in newspapers about COVID, right? We know COVID's here. Like, I don't need to be reminded COVID's here. We're not seeing information saying vaccine good, right? When we got a vaccine, I want people screaming and pissed off at the government right now because I want my vaccine, damn it, give it to me. And we're working on it, okay? So when the vaccine comes, they're ready for it. I don't want to say, okay, now we got a vaccine, now we're going to start our education program. Yeah, I don't really think I need a vaccine. So I think I got off topic there. Well, but I think we need to focus that ground level education, right? People drive what governments spend money on as much as needs do. And since a lot of this stuff is going to be somewhat behind the scenes for traditional types of funding and ongoing support, we need to make sure that we develop, interest in it.
I can jump in there too. And now I forget exactly what the question was, but I think about sort of moving forward, one thing that I really hope that we consider, and is probably one of the first things that gets forgotten, is about what sort of factors really drive zoonotic disease emergence. And we have so much literature that you can look back decades, and people will talk about, when we have dramatic land use changes and different types of agricultural intensification and changes associated with climate change and all of those sort of big things that have been drivers for so many different instances of disease emergence. And somehow we continually forget that, maybe we should be prioritizing how to change some of these things so that we can, start way upstream and think about how we might be able to prevent things like this from happening. And it's certainly not something that's easy. These are incredibly complex things, but I hope that it stays as part of the conversation because, again and again, we know that diseases are going to emerge. There's, it's just a fact of life, but there are things that we can do and assess that will make things less likely. And I would like that to be part of the conversation rather than just being like, okay, when the next one comes, this is how we're going to respond. Well, maybe we can decrease the likelihood that the next one's going to come, or it's going to be quite as bad. And so I think that's one of the things that I'm constantly thinking about, particularly with a One Health lens.
That's great. And Amy, do you have any sort of final comments to round off our panel?
Yeah, so I think, Katie's comment is a really great one, because I do think, there are going to be gaps that get identified when this is over. And maybe there will be funding to support specific types of, public health infrastructure, given all of the significant cuts that have occurred to public health. And then we realize, oh, those were providing really critical services, and, we really needed them. And then we were in a real pickle when this happened. And so, there's going to be funding, hopefully, for those sorts of things. But I think, as Katie said, we cannot forget the fact that, there is money for infrastructure to help respond to the next pandemic, to the next emerging infectious disease or public health emergency. But, Katie's comment about the fact that, this is not rocket science. We have a very clear list of things that increase the risk of zoonotic disease emergence. And so, they're not easy. And that's the challenge, right? It's easy to spend money on, hiring 500 new public health nurses in the province of Ontario. That's easy. What is not easy is, trying to work to reduce habitat destruction in places where we know pandemic diseases, diseases of pandemic potential might emerge. Mm-hmm. But that would that provides, so much benefit in so many different ways. Climate change, I think we do have to think much more holistically about things much further upstream, as Katie has said.
And I'm sure all the, if there's any social or behavioral epidemiologists on the line, they're all sort of echoing the same thing, that upstream is sort of where our best solutions lie. I just wanted to thank all three of the panelists, Amy Greer, Katie Clow, and Scott Weese. Thank you so much for your insights and involvement with the panel today. I really enjoyed the discussion that we had, and just really appreciate the time that you took this morning to be here with us today. And I just want to wish everyone a really great day. Thanks again, everyone, and bye for now.